Now continuing on the theme of health and disease, we're going to be talking about COVID. So Anna Piras is Associate Professor in Drug Technology Socioeconomics and Regulations at the Department of Pharmacy in the University of Pisa. She's on the editorial board of MDPI and received in 2006 the European Biomaterials and Tissue Engineering Doctoral Award. Her research interests are in pulmonary drug delivery and off-label drug administration. And so, Anna, you're going to tell us about aerosolised phosphodiesterase 3 inhibitor Enoximone in the treatment of COVID-19 pneumonia.
Thank you. Thank you for the nice introduction. And thank you to the organizing committee for giving me this opportunity. So today I'm going to talk about a work that was performed in collaboration between the Department of Pharmacy at the University of Pisa and the Department of Anesthesia and Clinical Care, the Hospital of Livorno in Tuscany, and the School of Pharmacy at the Trinity College in Dublin. So everything started in 2020 with the COVID pandemic, when the clinician had to face the COVID-related acute respiratory distress syndrome, and they need to find a way to try to restore the perfusion of the lungs and to recover the functionality of the lung. And thanks to an intuition of Dr. Ferro and Dr. Roncucci, they decided to try to administer Perfan that contains Enoximone, that is a phosphodiesterase 3 inhibitor. And that was first published as a letter to an editor in the Journal of Aerosol Medicine and Pulmonary Drug Delivery, reporting a single clinical case. So phosphodiesterase are present in every district of the body, and the phosphodiesterase 3 is mainly abundant in the cardiovascular system and in the lung at the alveolar macrophages, lymphocytes, monocytes, airway smooth muscle cells, and endothelial cells. And the inhibition of phosphodiesterase 3 leads to an increase of cyclic adenosine monophosphate and cyclic guanosine monophosphate, ending with a relaxation and bronchodilation, dilatation. And they also have anti-inflammatory effect because they inhibit human mast cell degranulation and prevent vascular leakage. So they are actually applied as a ionotropic and cardiac conotopy. But also there is a Professor Bout in the Netherlands that he is looking at Enoximone and is an inhibitor of PDE3 for asthma treatment. They have the application actually has several systemic limit systemic administration that is due to tachyarrhythmias and ectopic beats that are incoming. So Enoximone is commercially available only in a market product that is Perfan. Perfan is an intravenous solution that needs to be administered very slowly, and it is applied in congestive heart failure. And this slowly infusion is due to the fact that Enoximone is actually a stone. It is a stone because it's not soluble in water and tends to form crystals, as you can see in the right corner in this optical micrograph. So we looked at the composition of and the physical characteristics of this solution, and it totally disagrees to pharmacopoeia requirements for solution for nebulization, because there is propylene glycol, ethanol, and a very basic pH. So the question was, why is it working? Why it has this nice effect? So the aim was to acquire more clinical data in order to support what was the clinical evidence, also with more biopharmaceutical evaluations. So the outline of today is going to be the clinical study in a single center in Livorno, the aerosol deposition evaluation, and the biopharmaceutical characterization. What regards the clinical data, 14 patients were enrolled and administered with Perfan through nebulization. And the 65% of those were actually responding to the treatment with an improved lung function and oxygenation, reduction of cough, dyspnea, and breath frequency. And as you can see from this video of the electrical impedance tomography, it is possible to see how the perfusion is increasing after the treatment with Perfan and correlating with the improved oxygenation that was collected. So for what concerned the aerosol deposition study, the first attempt was by using a disposable breathing circle, by using a setting that was rearranged from the one that was published in a Nature scientific report in 2020. And we found out that actually only half of the delivered drug is inhaled by the patient. And those data were confirmed also by an evaluation in twin stage Impingers, and also by collecting the nebulized cloud, so the droplets. We could see that these crystals were forming both in the collected cloud and also in the cup of the nebulizer. And these crystals have a dimension that makes them they cannot be nebulized, so they remain inside the cup, and the delivered dose is very poor. And also the delivery rate is changing over time. But the good news was that half of the delivered dose was impacting in the second stage of the Impingers. And these data were also confirmed when we moved to the NGI evaluation that was used for long aerosolization times. As you can see, the entire dose takes about 1 hour to be administered. And in this case as well, we have a fine particle fraction that is about 60% of the delivered dose, and a mass median aerodynamic diameter that is around 5 micron. So that confirms that the delivery rate decreases, but that the dose that is delivered has a good aerodynamics to reach the lung. The Enoximone that is delivered through Perfan was also evaluated through a diffusion in an airway mucus, simulated airway, artificial airway mucus, and it is capable to diffuse in 5 hours up to 20% of the deposited dose. Moreover, we moved to the biological investigation. We were using this distal lung epithelial cell line, H441, and at first it was performed a screening on the cytotoxicity, and as you can see, we actually tested quite very high concentrations, up to 1 milligram of Enoximone. In all these biological evaluation, we use Perfan, and as control, we use a saline solution of Enoximone, so only the drug. The fact is that the drug is forming crystals on the cells. We have these nice crystals on the cells that we were analyzing, but by the way, there is no mechanical cytotoxicity revealed. The fact is also that Perfan is capable to keep in solution more Enoximone than what the saline solution does. For what concerns the air-liquid interface model, we standardized a procedure to have this air-liquid interface model based on H441 cells. It was characterized with transepithelial electrical resistance, stained with amatoxylin and eosin, and also we had a staining of the protein involved in the tight junctions. And this monolayer was placed and at the end of the second stage of the twin stage Impingers in order to have the deposition of the drug directly on the monolayer. And the resistance, the stability of this monolayer was evaluated, and it can resist up to 30 seconds of nebulization. But actually, for this study, we only need 1 second of nebulization. Only 1 second was needed because the 1.5 microgram of Enoximone is sufficient to perform the study. The nebulization of perfan directly on the monolayer was performed and allowed to the evaluation of the permeation of the drug and to the basolateral chamber. And as you can see, only when the drug is administered by using perfan, it is possible to have a diffusion on the lower basolateral chamber. And this is very important because, as I said at the beginning, one of the targets of Enoximone is going to be the pulmonary vasculature. And so it is needed that the drug is going to diffuse across the epithelial layer. Secondly, for the first time, it was evaluated the effect of this inhibitor on this cell line. We know that phosphodiesterase are present in the epithelial cells, and so we tried, and we saw that this low dose, that is 1.5 microgram, is capable to increase the intracellular count level, and that is only possible when the drug is administered with perfan and not when the drug is in the saline solution. So it looks like it is more bioavailable when there is perfan that is used. And moreover, since one of the indirect effect of the inhibition of the phosphodiesterase is an anti-inflammatory effect, we evaluated the possibility of protecting this layer from an oxidative stress. And the oxidative stress is present, of course, when there is the inflammation in the lung. And so also in this case, there was a very good effect of the drug when it was administered by using perfan. As you can see, there is the maintenance of the metabolic activity, so the viability of the cells when perfan was administered, and the cells were pre-incubated with it before the stress with oxygenated water. So, to conclude, the aerosolization of perfan is possible. It was effective in the 65% of the enrolled patient, giving rise to an increased oxygenation of and in a recovery of the lung functions. But actually there are technical limitations to the nebulization of perfan because it forms crystal. The delivery dose is very poor. Only 30% of it is going to be delivered to the patient. But this very low dose is actually active because perfan is boosting the Enoximone effect. And also the fact that it is permeating very fast is correlating to the quick relief that the patient feel once they are subjected to perfan administration by nebulization. So the take-home message is that perfan, it's a good tool for the management of ARDS, but of course, new formulation would be able to overcome the technical limitation for perfan aerosolization, and they will be very useful for the treatment of pulmonary pathologies. I would like to thank the Tuscany region for the funding, and also Professor Haley and Professor Avrad at the Trinity College for the collaboration. And I would like to introduce to you the team at the Pharmaceutical Technology Research Lab in Pisa. And also Brunella is here, and she is presenting with Magda a poster number 98. So I would like you to go and ask also to them about their research. Thank you all.
Fascinating work, really, really interesting.
Thank you so much.
So we've got some questions on Slido. Shall we just go to those, Regina?
Let's do that.
Because you're closer to it.
Okay. There's one question related to the permeability of your drug product. Do you think that the higher permeability in the in vitro model is due only to the ethanol which is present in the formulation? And don't you think that the PEG also has a role in opening tight junctions, for example?
Okay, yes. Actually, we would like to analyze the medium of the collected cloud in order to better reply or answer to this question. We know that ethanol is a permeation enhancer, so it surely is going to have an effect, but also the fact that there is an increased solubility of the drug. So the apparent solubility of the Enoximone is better when it's administered with perfan. And so, of course, also by a passive diffusion is going to be a better permeability. So it's a combination of effort, I think.
There are a couple of questions on just clarifying the nebulization time. So the nebulization time is an hour?
Yeah, it is. We tried different times for nebulization, and the perfan is a market medicine, so it is a fixed concentration, and the dose was supposed to be 50 milligrams. So the entire solution was nebulized in 1 hour.
Okay. And then there's another couple of questions on just clarifying that the phosphodiesterase 3 inhibitor acts on both the airway and the vasculature.
Yes.
You showed the airway, the oxidative stress model, and inflammation. You also commented earlier on vasculature. Can you expand mechanistically what it's doing in the vasculature?
Yes, the action is very similar because it is an inhibitor of phosphodiesterase 3, which are present in the vasculature, in the smooth muscle cells, and also in the endothelial, also in the epithelial. So the phosphodiesterase 3 is distributed in several types of cell lines. So the known effect of Enoximone is that of the intravenous administration. So the direct effect would be on the smooth vasculature. And so this is why this is the normal way it is applied. But actually, we're going to deliver that by the opposite way. So if the permeation of the Enoximone would allow an effect, suppose it's going to allow the effect also on the underneath vasculature, but also we saw an effect on the epithelial cell line. So it's both of them. But in the in vitro model, we only had the epithelial cell line. We are going to set up a model with both cell lines, one in the apical and the other one in the basolateral chamber, but that is another work.
Great, excellent. We've got so many questions, but maybe they can approach you in the break or indeed in the drinks reception later on. So thank you very much.
Thank you.